Okay,
Good
one
evening,
second.
sir.
I will just again go for the questions for you to. So, is it visible?
Yes, sir.
Sir, visible, sir.
So, this is like the case. Fixed flexion contracture in a 6-year-old girl. The questions
Yes.
are: what are the important points in the history needed?
We need to ask about the nature, time and the duration of the bone, cause of the bone, and we need to locate, location, the extension of the burns. Other than that,
Classify the burns. How is burns classified? What are the various methods of classifying burns?
burns classification. So the contracture or the burn?
Burns is classified as based on the depth of the burns, isn't it?
Yes, sir. Yes, sir.
Superficial.
Yes, sir. Only
Ah.
the superficial. Class 1 is only the superficial epidermis. Class 2 involves superficial epidermis along with the dermis, like less than 50%. Class 3 involves dermis along with some muscles. Class 4 involves the bones and the tendons and ligaments.
That is one classification. Another classification is the
Depends on the
etiology based on the
etiology.
causative agent, whether it is flame burn, whether it is liquid burn, or whether it is scalds, okay, whether it is chemical burn. So the agent causing the burns can also be taken as the classification, and whether the major or minor burn. So what comes under minor burn and what comes as a major burn? Then will you say, is this case a major burn or a minor burn?
It is a major burn, sir.
Major burn. Anything involving the face, neck, chest, or perineum, they are all called major burns. Okay, even if the degree or the extent of burn is less, the location decides whether it is a major burn or a minor burn. So this comes under the category of major burn. What is the classification of the neck scars and how is it important to anesthesia?
Sir, it can be classified into 4 types. Mild involves the anterior contracture. Here, the patient is able to flex the neck and bring the jaw and neck to anatomical position. In extension, inability to place an object located on the ceiling will be there. In moderate type, the anterior contracture will be there, but the patient able to flex the neck, bring the jaw and neck to anatomical position, but only during the erect, when the patient is erect. Extension away from the anatomical position will cause the pulling of the lower lip on the uninvolved side. In severe type of cases, the anterior contracture neck will be in the flexed position as in this picture. The patient will be unable to reach the anatomical position of jaw and the neck, and the extension, the eyes, the superior limbus of the unaffected eye will be covered, and inferior limbus of unaffected eye can be seen.
Okay, this is called mild, moderate, and severe degree.
Yeah.
The extent of burn, how do you classify? What is the formula that can be used for assessing the extent of burn?
So commonly used is a Parkland formula depending on the percentage of the total body surface area involved. 4 ml per kg into the total body surface area.
No, I'm asking not about the fluid, the extent of burn. How do you classify
Rule of
the
9, sir. 9, London Brown.
What is the rule of 9? And who described that?
Valleys, sir. Valleys rule of 9.
Yes, for children.
London
Brown chart.
Brown and Ladder. Okay, so these are the two formulas that are used, and using that you have to, that extent of burn calculation is important for fluid management. Okay, so don't confuse Parkland formula immediately with the extent of burn. It is fluid resuscitation, Parkland formula you have to show. Now, what is the pathophysiology in burns? Why patients become dehydrated in burns? Unlike a trauma, there is no obvious blood loss. but they become dehydrated and you have to give high volume of fluids. Why?
Increase in vascular permeability will be there. So sudden fluid shift, vascular volume depletion, sir. These patients will have reduced vascular resistance and inflammatory response will be high.
The burn destroys all the cell walls, okay, and the vascular permeability, as you said, is also more. So fluid seeps into the interstitial spaces, and the whole tissues become edematous. So patient bleeds into himself, or loses fluid into himself, in his tissues himself, even though there is no overt blood loss or fluid loss. Okay, so that is how the patient becomes hypovolemic or dehydrated. So they require. So how is fluid resuscitation done in major burns? What are the formula that are available? One is the Parkland formula. Another is the, what is the alternate to Parkland formula?
Brooks formula.
Brooks formula. What is the difference between the two?
Brooks formula, the volume what we give is reduced, like 2 to 3 ml per kg.
Both of them are more. Brooks also advocates use of colloids, whereas Parkland advocates only ringer lactate. Okay, that is the difference between the Brooks and Parkland. And how is the pain managed in the first and second degree burn? That is where the epidermis and dermis are injured or destroyed. Why that is more painful?
The innervation is very high in the dermis.
The bare nerve endings are exposed. Okay, so they become irritated and get irritated, and they cause the severe pain in first and second degree burns. So how the pain is to manage? What are the methods?
Paracetamol and low dose narcotics, gabapentin.
Gabapentin is for neuropathic pain, not for burns pain. Have you heard of the cocktail, TMC cocktail?
No, sir.
No. So tramadol, midazolam, and ketamine, they can be mixed in the same syringe, then given as a slow IV infusion of 1 to 2 ml per minute and per hour. So 100 milligrams of tramadol, 5 milligrams of midazolam, and 100 milligrams of ketamine. So 100 milligram tramadol is 2 ml, 100 milligram of ketamine is 2 ml. You have 5 milligram per ml midazolam available as an ampule. So mix all these things, you get a total volume of 5 ml. To this you add 45 ml of normal saline to make a total volume of 50 ml, and give this as an infusion for 2 to 4 ml per hour, which will provide an excellent pain relief for the first and second degree burn pain. Okay. And the challenges in managing burn patients for hysterectomy. So initially, when the burn occurs, the majority of the tissues are destroyed and they become non-viable and they start separating. That is called the hyster. So what are the challenges in managing a burn patient for the removal of the dead tissue or hysterectomy?
This
Again, have any of you managed these cases during your training now?
few scans and the
Adults,
most.
adults contracture we have seen.
No, this hysterectomy, acute burns, how many of you have seen being managed during this period of your training?
No, sir.
No. Again, that is a drawback. Okay, right. So hysterectomy is removal of the dead tissues, and during that time, neovascularization occurs. Lot of new vessel formation occurs to heal the tissues. So while you try to remove the superficial dead tissues, lot of new vessels would have sprouted underneath, and there will be a heavy bleeding. And if these sort of burns are there over the chest, arms, and all that, where will you place your electrodes, ECG electrodes, for monitoring the ECG?
posterior aspect we can place.
If the back is not burnt, you can put there also. But if the back also is burnt,
we can put on the foreheads.
you can put on the forehead. ECG electrode. Supposing you have a face burn, chest burn, both front and back, arm up to the forearm, how will you monitor the ECG in these patients? Okay, you think and find out and tell me the answer in the next class. Let it be in homework for you. Okay. So challenges are lot of hemorrhage, number one. Number two, monitoring, placement of NIBP, pulse oximetry, the ECG, everything will be a challenge in doing an hysterectomy in an acutely burnt patient. Third will be airway difficulty. Patient may have a very solid, once it forms an eschar in the neck, it will be very difficult. It will not be a supple tissue to extend the neck and put your scope, and airway challenges will be there. And four, these patients will become hypothermic because you expose the patient, and surgeon will be going on washing the wound with saline, cold saline, to stop the bleeding as well as to clear the dead tissues. So patients can become hypothermic. So four challenges you have to remember for hysterectomy are: one is hemorrhage. So in Western countries, unless you reserve 6 bottles of blood, patients are not taken up for hysterectomy. That amount of blood loss will be there. Second thing is monitoring difficulty. Third thing is airway difficulty. Fourth thing is the hypothermia. And fifth thing is they become more resistant to non-depolarizing muscle relaxants. Can you tell me why they become more resistant to ND blockers?
Yes, sir. There will be a proliferation of extrajunctional receptors.
Fantastic, very good. So there is a more proliferation of extrajunctional receptors. So patient will come out of ND blocker very fast, and you are not supposed to use which relaxant?
Scolin, sir.
Dexamethasone. That will result in hyperkalemia. Okay, so these are the 5 challenges you have to remember for hysterectomy. Now, how to secure the airway in this case, especially this contracture, this particular case that they have given you? What are the methods of securing the airway? The answer they expect you is 3 answers they expect in the exam. What
Sir,
are
I
the
did
3
awake
answers?
or asleep fiber
What is the
optic,
first option?
awake fiber optic intubation.
Awake fiber optic intubation. Fantastic. Under topical anesthesia. That is the complete answer. You cannot just do awake and without topicalizing or anesthetizing the airway. But a 6-year-old female child, will they cooperate?
No, sir. We can go for asleep and fiber optic intubation. Like mild sedatives can be given.
So you can sedate. Is there a chance of airway obstruction occurring? How do you sedate? Intravenous or inhalational?
I'll go with intravenous, sir.
Always the answer is you can sedate the child with inhalation induction. After applying the topical anesthesia, you induce the child with inhalation induction and then perform the fiber optic examination and proceed to intubate. The second option is releasing the contracture for adequate neck extension by local infiltration. So you can continue again because 6-year-old may not cooperate for that also. So you can induce the child with the inhalation induction. Always preserve spontaneous ventilation. Never paralyze a child in a difficult airway like this. So preserve the spontaneous ventilation and take the patient deep to the surgical plane of anesthesia by inhalation induction. And then you can infiltrate local anesthesia into the scar and quickly ask the surgeon to release the scar for adequate neck extension. And once adequately released, where you can do a laryngoscopy, you can give a relaxant and intubate, or you can, in the same deep plane of anesthesia, you can put a scope and intubate the patient. The third option is to release the contracture with emission local anesthesia. Okay, these are the three answers that we have to give. What are the other challenges? Apart from airway, what are the other challenges?
Difficult IV line, sir.
Monitors and
venous
IV lines.
access may be especially if upper limb or both lower limbs are all burned. IV access may be quite challenging.
This can
Monitoring
be
will be
malnourished.
challenging. Positioning will be challenging. If you in a fixed flexion, if you keep the patient in the table, the neck may not touch the pillow. So you have to give adequate support on the back and head to support the pillow. I mean, position the patient. And again, blood loss may be there and hypothermia will be there. And post-operatively, if they do a release and skin grafting, proper immobilization is very important. Otherwise, the skin graft may come off and the wound will not heal. So they may come again for regrafting or secondary grafting. Okay? And post-op pain relief should be adequate so that they don't move and become restless to make the skin graft dislodge. So that is, these are all the post-op management. Okay, so these are all the points. And other things they may ask you is about the how do you proceed with fiber optic? What are all the nerves that you block for the airway anesthesia? All that I think we have already seen in one of the class discussions. Do you all remember what are all the nerves to be blocked for fiber optic intubation? You do a nasal or oral route, what are all the nerves you have to block? Nowadays, you do what you call pray as you go, SAGO. Okay. So that is the easiest method. You don't have to remember the nerves, but in the exam, they will ask you what are all the nerves you have to block and you have to name them. So please go and read about that. We close the discussion on the three